Well, thanks so much. I think we'll continue with this next talk. I'll try to make it brief so that we remain on schedule. Again, on behalf of all my colleagues back in New York, it's a real honor for us to be participating and collaborating with you here at this conference. And that live case session was a great way to start the morning. I'll sort of continue on the topic of stents and drug-eluting stents in particular and speak to the major the biggest issue with stents in the current era, and that is stent thrombosis. I have no conflicts related to this talk. I think that despite all the improvements in terms of restenosis and safety with drug-eluting stents, although stent thrombosis still occurs at low frequency, it is still the most devastating complication that can occur after a stent is placed. And as shown here on the slide, ST elevations, occluded arteries, and high rates of not only large myocardial infarctions, but also mortality relating to stent thrombosis. And something else that's emerged is that stent thrombosis can also be recurrent, and that's something that is even more sobering for patients that have these large events. As Dr. Leon mentioned initially, stents were held back to some degree based upon not only issues relating to restenosis, but also specifically relating to thrombosis. In the early experiences of the Palmade shot stent, the rate of stent thrombosis approached approximately 20%. And that was just frankly too high to allow the safe usage of these devices, even for cases of severe dissections and abrupt closure. But with advances in terms of not only high pressure inflations through colleagues like Antonio Colombo, who will be transmitting later today, but also further iterations of antiplatelet therapy, not just thrombotics, but antiplatelet therapy as initiated by Dr. Leon, Dr. Sorois, and others, we found thrombosis rates in the bare metal stent era dropping below the 1% margin. And really it was this development that allowed stents to be used so much more widely, because if you could place them in safely and not have these thrombotic events occurring, then they had much more widespread appeal. Initially, it was thought that the majority of these thrombotic events, in fact, all the thrombotic events, it was thought initially occurred within the first 30 days and particularly within the first 2 weeks. But what's actually been now demonstrated, particularly in the DES era, is that while the majority of events, 2/3 of them, do occur early within the first 30 days, there are also thrombotic events occurring, approximately a third of the cases, beyond even 30 days, and in some cases beyond a year. And this is why I think thrombosis, if it can be reduced, will really be the last hurdle to overcome with respect to the further up-titration of DES use. So the traditional way of looking at stent thrombosis is relating to not only the patient and specific risk factors of the patient profile, but also the type of device that's used, and there may be differences in the devices, and then how we actually implant the devices. And because as interventionalists, stenting is so easy nowadays, we often neglect this aspect of the therapy, but in reality, that's one of the few things we can actually control. And so I think it's very important to focus on technical aspects of the procedure so that we can minimize thrombosis to even lower levels than we currently see. As far as the patient risk factors go, there's many publications on this, and typically the highest risk features really include things like acute coronary syndromes, patients with renal failure, severe diabetes such as that requiring insulin, and additionally, if you were able to stop clopidogrel, if you stopped it prematurely, that does appear to be a heavy risk factor for early stent thrombosis. The issue of technique and what we can do in the catheterization laboratory to minimize stent thrombosis is also important. And some of the things that initial IVUS studies have shown us is that if you don't leave residual disease and dissections behind, in fact, if you identify them and treat them appropriately and keep the flow going through the stent, you can actually lead to lower rates of stent thrombosis from occurring. Another issue besides residual disease and dissections relates to the actual expansion of the stent itself. These devices are meant to be expanded, and that actually increases the chance that you have nice homogeneous flow through the stent as opposed to a vortex of blood flow that can serve as a nidus for thrombosis. And so stent expansion, particularly in calcified lesions, is important. High pressure post-dilatation. Don't just throw the stent in and get out and move on to the next case. Make sure you optimize the stent results throughout the entire length of the stent. These are going to be very important factors. And while they may not impact large numbers of patients, remember the thrombosis rate is 1 in 100 or 2 in 100. If you do a lot of cases, this will affect true patients that you treat. And then additionally, trying to minimize extensive stent hardware, and this has now become a theme, not only with the results of trials like FAME, but also in general, we try to use less, use just what's needed to adequately treat the patient, and I think that can be important. How about the actual devices themselves? Well, strut thickness, independent of whether you use a DES or a bare metal stent, is important. This is data that was actually just came out last year in Circulation, looking at strut thickness in a benchtop model that actually looked at thrombogenicity. The strut thickness that was thinner was associated with less thrombogenicity. In addition, polymer coatings or stent coatings can actually affect the actual thrombogenicity of a stent product. And so in this study, a fluoropolymer coating was associated with lower thrombogenicity than compared to even a thin-strutted bare metal stent. Now, what about the pharmacology? That's also important, and we tend to sort of assume that the pharmacology is just a part of the procedure, but if we think about it, we can further reduce the rates of stent thrombosis, particularly early stent thrombosis. This is data from Horizons AMI demonstrating that more potent antiplatelet inhibition with a glycoprotein 2B3A inhibitor is associated with lower rates of stent thrombosis while that agent is being given. And similarly, platelets, just in general, and oral platelet agents have been shown clearly to reduce the rate of stent thrombosis. And as I mentioned earlier, this is what led to the more safe and widespread applications of coronary stents. These initial 5 studies really demonstrated the superiority of ticlopidine-based strategies in addition to aspirin compared to aspirin alone or aspirin plus warfarin, but we've now moved on to using clopidogrel predominantly because of the more effective side effect profile of clopidogrel. But as we all know, clopidogrel is a prodrug that requires metabolism in the liver to its active form, and there's variability in terms of that metabolism, and therefore variability in the responsiveness of the body to clopidogrel. And there are therefore patients that are hypo-responsive, non-responsive, and even potentially hyper-responsive. It does appear that clopidogrel responsiveness actually can impact the results of stent thrombosis. This is the ADAPT DES study, which was presented at TCT last year, and the 1-year results will be likely presented at TCT this year, basically showing that if you had poor responsiveness to clopidogrel, that was associated with an increase in stent thrombosis. The problem here is that there's a large overlap of patients that have poor responsiveness that don't actually thrombose. And as a result, to tailor therapy and to change your medications based upon responsiveness is not something that's been shown to be efficacious thus far. Now, why do you get this hyporesponsiveness? There's been a lot of study into genetic genotyping to basically determine who patients are that would not respond well. There does appear to be polymorphisms in the CYP2C19 gene that can impact overall platelet responsiveness to this agent. And in case control studies, this has been demonstrated to be a relatively potent predictor of stent thrombosis. But again, because the incidence of stent thrombosis is so low overall, just because you have this mutation does not necessarily mean you'll thrombose. It is interesting, though, if you do have these mutations, you can overcome this resistance or this hyporesponsiveness by increasing either the dose of clopidogrel in this case of carriers, or in the case of a homozygote, actually switching to another agent that's not affected through the CYP2C19 metabolic pathway. There have been numerous clinical data on this. This is the data from the current OASIS 7 study by Salim Yusuf's group, showing that in acute coronary syndrome patients, if you double the dose of clopidogrel, you can reduce the rate of stent thrombosis. Additionally, if you use other medications such as prasugrel, as shown in Triton TIMI 38, you can lower the rate of stent thrombosis. And similarly with ticagrelor, which I think is now going to be available in India, you can lower the rate of stent thrombosis with the use of a more potent antiplatelet agent. The most critical aspect, though, is not so much the potency, but if you're not taking the agent, then you have no potency. And then this was clearly demonstrated in the PREMIER registry, which showed that even among patients with acute myocardial infarction, approximately 15% of patients were not taking thionopyridines at 30 days, and this was associated with a dramatic increase in the incidence of stent thrombosis. So that's predominantly early stent thrombosis that I've spoken about. What about late stent thrombosis, or that occurring beyond the early period? As Dr. Leon showed in his slide, this was recognized early on with both Cypher and Taxus that there were events accruing beyond a year, in fact out to 4, 5, and 6 years and beyond. So if we can try to predict these clinically, we might be able to help our patients. Well, it turns out that it's very difficult to predict up front who's going to have these events. This is data from a large case control study. Dr. Leon was the co-PI of the study along with Ron Waxman, essentially showing that no real clinical risk factor was able to predict the incidence of late stent thrombosis. And so this is somewhat sobering because it means that there's not much we can do to identify these patients. What's the cause of these late events? It's always been hypothesized, at least for the past 5 years or more, that this is adverse reaction to the polymer. This is late inadequate healing, and this was demonstrated in early histologic studies by Alok Finn and Renu Vermani, published in Circulation, really showing that if you didn't have endothelialization of stent struts, or you had malapposition or uncovered struts, that was a clear precipitator for late stent thrombosis occurring. This has now been substantiated through OCT and IVUS-based imaging studies in vivo, and this is data from Guayumi's group showing that if you look with OCT or IVUS and you demonstrate their uncovered struts or malapposed struts, this is clearly associated with a reasonable hazard of very late stent thrombosis. So it does appear that there's an adverse healing response taking place. So can newer stents overcome this? And this is data from Berman and Rotterdam, really demonstrating earlier in this year in Circulation that with the Xience V stent compared to Cypher and Taxus, the rate of very late stent thrombosis occurring beyond a year is actually much flatter than with the older first-generation stent devices. This is not isolated to the Xience V stent. This is data from the Endeavor 4 trial, again showing very low rates of very late stent thrombosis beyond a year, presented at TCT last year. And similarly, data with the Biomatrix stent, a bioabsorbable polymer stent, has demonstrated very low rates of stent thrombosis, and this was presented in the Lancet, particularly beyond 1 year and occurring from 1 year to 4 years. The final aspect I'd like to talk about a little bit is the duration of dual antiplatelet therapy, and Sushil brought this up in the last live case. It's still unclear as to how long we need to treat these patients. And the reason it's unclear is because the recommendations that are typically been followed were empiric and based around the time of 2006, which was the whole ESC firestorm, and I think we were reacting a lot and wanted to prevent stent thrombosis any way we could, even if the data wasn't particularly there. So when you look at discontinuation in large series of patients, what you find is that if you discontinue within the first 30 days, that's a clear risk factor for stent thrombosis. But beyond 30 days, the risk or the hazard of discontinuation starts to become less and less. And in fact, if you look at the reasons that people discontinue, only about a quarter of people discontinue for a major bleeding episode or major surgery. There are a lot of times that people will just discontinue it for more minor things. So I think the one key aspect is that if you can try to educate patients and try to keep them on the therapy, especially within the first 6 months or so, you can hopefully improve outcomes. But beyond the first 6 months, in fact, beyond even 30 days in some cases, it does not look like discontinuation may be that great a risk factor for stent thrombosis. And in fact, there have been randomized trial data coming out now, and this is the Prodigy study, that looked at 6 months versus longer duration dual antiplatelet therapy in a randomized trial. And what was shown in this trial is that there was no difference in adverse ischemic events from a strategy of long versus shorter dual antiplatelet therapy, but there was actually increased bleeding associated with continuing the dual antiplatelet therapy out beyond a year and even past that. This data was also similar to the data presented by S.J. Park's group in the New England Journal, looking at shorter duration versus longer duration dual antiplatelet therapy. Absolutely no difference in stent thrombosis between these two strategies. And similarly, in fact, with the second generation stents such as Endeavor and Xience, there have been studies looking observationally at patients who actually stopped their dual antiplatelet therapy beyond 6 months. This was presented at JACC Interventions last year. No difference in patients that had stopped at 6 months, or actually at 12 months in this case, versus those that continued beyond 12 months. And the RESET trial, which was presented at the ACC, was a trial of 3 months of dual antiplatelet therapy with Endeavor versus longer duration antiplatelet therapy with Resolute, and really there were no differences in stent thrombosis with a 3-month strategy with Endeavor. So I think that this is very compelling data, and combined with some of the data on Xience V showing that at 3 months you can generally stop, and in fact Xience V now has CE mark for 3 months of dual antiplatelet therapy. The whole issue of do we need to continue dual antiplatelet therapy beyond 3 and 6 months, I think is a major question right now, and I think many of us are actually peeling off dual antiplatelet therapy earlier than we used to in the past. So I think in conclusion, just how can we minimize stent thrombosis? I think first we need to pick our patients well. We need to screen them for adherence, particularly within the first 30 days and even up to 3 to 6 months, specifically screening them for potential bleeding risk and also for any upcoming procedures. I think we also need to pay a lot of attention to what we do in the cath lab, continue the most appropriate use of post-dilatation, consider possible IVUS, and then pick devices that have been shown to be more efficacious in this regard. And I think many of the second and third generation and beyond stents are going to be very, very beneficial in this regard. Try to avoid excessive stent use and treat residual disease aggressively. And then I think finally the issue of continuation is a little bit unclear. We do want to make sure that we use more potent antiplatelet regimens in the appropriate clinical scenarios, such as those with acute coronary syndromes, and then patient education and clinical follow-up, close clinical follow-up, reiterating with patients the importance of these therapies is ultimately going to be critical. So I want to thank you for your attention. This was sort of a tour through what we know about stent thrombosis now, and I think we'll move on to a more visionary talk about the future applications of the devices and others in interventional cardiology. Thank you.